So, hello everyone to the third NeoIPC Project Clinical Practice Network webinar. It is dedicated to surveillance, which in the broad sense is the monitoring of behavior, activities, or information for the purpose of information gathering, influencing, managing, or directing. And that's exactly what surveillance also in NICUs is aiming to change practice in favor of our tiny patients. To start with, I would like to draw your attention to the Clinical Practice Network itself, which is a part of the NeoIPC project. The project overall has been called into life to establish innovative approaches for optimal infection prevention of resistant bacteria in NICUs. And the Clinical Practice Network aims to bring together connected and interested units in an international network of clinical practice. I'm happy to say that we have an increasing coverage of the whole world, with currently 128 members from 86 institutions in 29 countries, covering really most of the world. Our website is also a repository of a number of guidance documents, recommendations, opportunities for training and sharing your experience, which I would recommend for you to visit. But given today's subject, I will be happy to give floor to Julia for the introduction of our first distinguished speaker.
So thank you, Tuli. So many of you will not know me, so I'll just briefly say 2 words about myself. So my name is Julia. I'm a pediatrician specializing in infectious diseases and infection prevention and control. And I coordinate the NeoIPC project with Tuli and others in charge of leading our CPNs, or our clinical practice network activities. And we're very pleased that several of our partners and colleagues with experience in this area are with us today to share some of their insights and experience with all of us. So it gives me real pleasure to first introduce to you Aikaterini Mougkou from ECDC. She is an observer on our independent advisory board and therefore supports us with some of our thought gathering around our activities. She's a pediatrician. In fact, we've worked with each other before. She went, she joined ECDC, so this is a long-standing collaboration. She has experience in pediatric infectious diseases and IPC, and has joined the ECDC in 2020 in the diseases, a program for antimicrobial resistance and healthcare-associated infections. So Aikaterini, the floor is yours, and we're very interested to hear your perspective.
Thank you very much. Thank you for the invitation. It's a great pleasure to participate to this webinar. So Valentina, if you could share my slides, please. Next slide, please. Thank you. So as I'm the first speaker, I will start my talk explaining what surveillance is, what is the role of surveillance both in public health level, but also in the hospital level. I will also talk very briefly about the types of surveillance and what we should have in mind before we start collecting data. I will present you the ECDC surveillance network, how the ECDC published data support the initiative of NeoIPC project for a specialized neonatal surveillance network. Next slide, please. So surveillance is a dynamic process for collecting, analyzing, and disseminating data that should lead to actions and interventions if they are necessary. I underlined in the slide the words communication and dissemination, because if we do not share the results and inform the relevant stakeholders about the findings, then we have wasted time and resources to just collecting and recording data. Next slide, please. So surveillance is the cornerstone of any infection prevention control program, as it provides data on baseline infection or colonization rates, monitors trends, evaluates the impact of interventions, helps the clinicians to choose the appropriate treatment. If doctors know what the most prevalent pathogen in their own unit is, then it would be easier to treat their patients with the appropriate antimicrobial. Surveillance also helped to detect outbreaks and also to monitor compliance with the hospital policies and practices. And a big advantage having surveillance data is that help the IPC prevention control staff to convince clinicians and hospital administrators that there is a potential problem. And I will come back to that later, as it's quite important. Next slide, please. So there are several types of surveillance. Therefore, it's important to choose carefully what type is more appropriate. Is it active surveillance, where it detects every case but requires more time and resources, or passive surveillance, when data are collected from existing medical or laboratory reports and utilizes the existing infrastructure, but maybe not all cases will be captured. So an example of passive surveillance is the notifiable disease surveillance. Will it be a total house surveillance or a more targeted one and focus in particular hospitals or particular units or specific group of patients? A hospital-wide surveillance, for example, can be expensive, labor intensive, and in the end of the day, maybe needless, because not all the units face the same problems, not all the patients have same type of infections or undergo similar procedures. So it was to take the time and decide carefully what you really want to measure and where. There's also the syndromic surveillance, where monitor symptoms or clinical syndromes, versus the laboratory-based surveillance that identifies cases through the laboratory testing. All surveillance types have pros and cons, so it's really, it depends on the specific needs of each hospital. It can be also voluntary or mandatory, like it is in some states in the US, that hospitals not only should monitor their infections systematically, but they should also publish the reports, and patients choose the hospital they're going to visit according to the hospital infection rates. Depending on the available infrastructure, automated surveillance can be also an option. And compared to manual surveillance, where the IPC staff has to actively go and search for possible infections in the medical records, the automated electronic surveillance systems use algorithms that identify patients with infections and generate alerts or notifications. And finally, surveillance can be also in a local or a national or international level, or within a network. And this gives the opportunity for comparisons among similar units and with the same methodology. Next slide, please. So what exactly can we measure by doing surveillance related to IPC? Healthcare-associated infections. They are the most frequent adverse effect related to healthcare worldwide. Millions of patients develop a healthcare-associated infection every year, resulting in more deaths, more disability, longer hospital stays, and of course, increased financial costs. However, the good news is that many of these infections can be prevented. And the first step for their prevention is to identify them through surveillance. We can also collect data on antimicrobial resistance, antimicrobial consumption, hand hygiene compliance, consumption of alcohol-based hand rub, and adherence rates to practices such as central line insertion practices. Next slide, please. Before we start surveillance, we should ask, why do we need the data? What is that we would like to monitor how we will collect the data and what we are going to do with the data, what kind of reports we will produce, to whom we will communicate the results. And is the data likely to influence change? So depending on the answers, we will then choose the appropriate indicator to monitor the healthcare setting. We may do not want to include all the neonatal units, for example, with high-risk infants. We should also explore the available data sources. If will be the patient records or lab results. If we need data on antibiotic use, maybe the hospital pharmacy can provide some data. And then how feasible is to collect the data. And from my own experience, one of the most difficult procedures is to collect the denominators for the device-associated infections. For example, the central line days that are necessary as denominator for the CLABSIs, for the central line-associated bloodstream infections. Standardized case definitions are also very important. What is called infection according to an epidemiological surveillance definition may not meet the criteria for a clinical diagnosis. So we should be clear which definition is used. And as I mentioned in my first slides, it's crucial to communicate the results. And this is why data should be meaningful. We do not collect data for the data. The data analysis and interpretation should provide useful information to those who can act on the findings and improve the patient care. It can be the hospital directors or policymakers, but also the healthcare workers. Next slide, please. So I told you in the beginning that surveillance data are necessary to convince clinicians that there is a potential problem. Why is that? Usually, when IPC staff visit a unit, asking the unit director and the staff there if they have observed any healthcare-associated infections in their unit, the reply is, we do not have any infections. And if you ask for the evidence, they admit that they don't have data, but they know. So to implement interventions and to prove that there is actually a problem, it's very important to have data. Without data, nobody can prove anything. Next slide, please. So I want to present you now a very, very simple scenario for all of us to understand and be on the same page when we discuss about surveillance of healthcare-associated infections. And let's say in the hospital X in November, both units A and B had 7 infections. So which unit is doing better? It seems that maybe are equal, right? Next click, please. So what if I tell you that the hospital A in November had 10 hospitalized patients while the hospital B had 100 patients? Do we still think that both hospitals have similar IPC practices? So now that we know the denominators, it seems that hospital B is doing a bit better, right? Has lower infection rate. But we only have data for November. What happened the previous months? Let's see. Next click, please. So hospital A started with high infection rates and during the last year has managed to decrease them. So not bad. Next click, please. And hospital B doesn't seem to have a decreasing trend, and particularly November had the highest infection rate. So this is why both numerators and denominators are needed to be recorded systematically so that each unit has baseline rates that can be compared not only with other similar units, but also to be able to identify increasing trends or even outbreaks. Next slide, please. And let me present you the ECDC surveillance networks now. Next slide. European countries participate in the Antimicrobial Resistance Surveillance Network, the AMR Genes Network, the ESACnet for antimicrobial consumption, and the HAI-net, including the healthcare-associated infections in acute care hospitals, in ICUs, in intensive care units, and surgical site infections. Next slide, please. So at ECDC website, you can find the surveillance atlas. You just choose the type of infection, the country, and you can see in the map all the available information. Next slide, please. For example, with the data provided by the European countries, on intubation-associated pneumonia and central line-associated bloodstream infections, we can monitor the trends of these infections at the European level. Next slide, please. Using data from the ECDC point prevalence survey of HAIs in acute care hospitals, colleagues estimated the burden of 6 common HAIs in DALYs, which means disability-adjusted life years, taking into account not only the number of cases, but also the associated mortality, the short-term and long-term disabilities that result from a healthcare-associated infection. So in this slide, you see the distribution of the burden of HAIs in DALYs per 100,000 population by gender and by age group. And the highest burden is the age group less than a year old. Next slide, please.
Next slide.
So using antimicrobial resistance data this time, colleagues estimated infections attributable to antibiotic-resistant bacteria in DALYs. And guess what? The burden was also the highest in infants. So it's obvious that this age group of patients hospitalized in the NICUs, in the neonatal intensive care units, needs more than anyone else good IPC practices and accurate and reliable surveillance data. Next slide, please. There are many studies showing that implementing interventions can improve the infection rates and the IPC practices. And the nice example is Germany. It has very good national HAI surveillance network, including the NICUs. And this paper describes how the incidence density of bloodstream infections decreased significantly by 24% within 3 years. So they prove that NICUs, by participating in an ongoing HAI surveillance and by feeding back individual NICU with their own data for comparison with reference data, can decrease infection rates. Next slide, please. So I'm a pediatrician, and I believe many of you work with children too. So we all know that most of studies and data involve adults, which is a different population group, and therefore we need more data. And particularly neonates, they have different needs, they have different risk factors. And even the whole NICU environment differs a lot from an adult intensive care unit. The IPC practices are different, the types of infections, the antibiotics, many things are really different in the neonates. Next slide, please. So this is why we need more data on this specific population age groups, the neonates. And I'm very glad that the NeoIPC project works towards that with the NICUs network. And you know what they say, the more the merrier. So you're more than welcome to join the network. Next slide, please. Thank you very much.
Wonderful. Thank you so much. I think what we're going to try and do is have everything as a discussion at the end, if that's okay, Katerina. So if you have some clarification questions, feel free to maybe put them in the chat so that we can gather them and make sure that these get asked, or if there's something super urgent, then we can also raise it now. Otherwise, I will hand over to Tuli and we'll all get back together at the end.
Thank you, Julia. Our next speaker will be Dr. José Ignacio Zubizarreta, who is a member of the Spanish team of the NeoIPC project with a long-lasting practical experience in neonatal hospital infection surveillance. He's a doctor trained in internal medicine, but also has master's degree in clinical epidemiology and is currently working for the clinical epidemiology unit of the Clinical Hospital Universitario Cruces. Please, José, the floor is yours.
So, okay, well, so good afternoon. It's a big pleasure for me to be here with you. And I want, first of all, to thank all the people in charge of the CPN of NeoIPC, because it's a good opportunity to just to think about our way of doing things, to recover some of our data and to think about our past experience. Secondly, I have to remark that this is a cooperative work. Although I am the spokesperson just right now, there are other people involved in this speech. And for instance, it's very important Begoña Obiero, because she is the neonatologist working at the unit and coordinating all the perinatal research work from our hospital. So briefly, I will try first of all to introduce which kind of hospital we are working in. It's in Spain, in the north of Spain, in the Basque Country, and to explain that our experience with surveillance is a mix. It's at the crossroads between research, quality improvement, and routine care. So you can on the top left, you can see our hospital when it was built in the middle of nowhere, in the middle of the green fields of Basque Country. Now this hospital has been surrounded by a lot of buildings. It's in the middle of a very populated area, a lot of cars, a lot of noise, a lot of people. It's a third-level university hospital covering about 300,000 inhabitants with some 800 beds, 3 intensive care units, the adults, the pediatric, and the neonatal. It's a lot of operating rooms, very, very surgical hospital, let's say that. And it's a regional reference center in Basque Country for transplantations, the Brar unit, cancer care, cystic fibrosis unit, pediatric cancer, rare diseases, etc. It has also attached since 2014 and accredited by the Spanish Ministry Health Research Institute. And this is the unit. The neonatal unit is a level 3 CH unit, which is the highest level recognized or acknowledged in Spain. It is composed of 12 intensive care cots, 38 in overall, and has 13 neonatologists, most of them, I think, almost 12 women and one man. And you can see the number of nurses, 42 nurses and 27 nursing auxiliaries, plus 1 supervisor and 1 clinical nurse. In terms of neonatal care, it's also a reference center for heart surgery, some other complex surgeries, as also ECMO available. And the hospital has about 4,000 births per year, with some 350 units admitted, around 50 less than 1,500 grams of weight, adult weight. And of course, some of these babies are transferred from other close hospitals. So these 2 people, you have you are lucky because one of them is here in this webinar. These 2 people are responsible for all or most of our hospital's story about surveillance, because the one on the bottom right, Professor Adolf Valls, he was the head of the unit. He was very much involved in the international and national research, and he got some grants from the European Union, from DG Sanco, and started running an European network called EuroNeonet, whose aim was not specifically infection, but just mortality and morbidity. He could soon appreciate that German units in general have very low sepsis rates, and Spanish units and our own unit sepsis rates were much higher. So in some meeting, Adolf met Brar, who is a member of the Charité, and he's responsible of the NeoIPC very well-known surveillance system, specific for neonatology and other areas of healthcare. And Adolf asked for permission to the German group, for just translating and adapting the successful German system to Spain. After that, and from research grants, we started the NeoIPC Spanish surveillance system, which was only limited to sepsis, was more limited than the German NeoIPC, and was working on a voluntary basis. So every unit couldn't or could not just participate. Here you can see that all over the years, it started collecting regular data in 2014 and sending the first report, the first feedback report in 2015. The number of units, little by little, has been increasing. Okay, you can see here the cover page of the annual report, which is very, very complete, I think. And you can see that there are quite a few Spanish units. Overall, they represent 81% of the highest, the three level of care units in Spain, which is quite a big figure, just because we are talking about voluntary participation. And you can see one of the plots, one of the graphs that this report produces, the caterpillar plot, where you can locate with the code where your unit is in terms of different sepsis rates according to gestational age, birth weight, etc. From this surveillance system, we could just appreciate that our unit, Cruces unit, had quite high level of sepsis rates. We can see the overall rates per 1,000 days of stay at the NICU, or the CLABSI SEPs associated to central line. They were stable in high figures. So it became clear to us that something had to be made, and there was an action put in place. The first action came from hospital and unit heads or managers, and it consisted of just starting to look for colonization. So there were a strategy to detect some gram-positive and some gram-negative bacteria with weekly sampling, nasal swabs, pharyngeal swabs, and rectal swabs. And currently, we are still doing this colonization detection surveillance strategy. The second one came from the research team I belong to, and just learning from the key work from Professor Provost, published in the New England Journal of Medicine in 2006. His team showed that it can be, these sepsis rates can be just decreased by using systematically just a not big number of interventions, and we from the experience and some other experiences published from other groups in all of the world, some of them just belonging to neonatal units. We started a research project trying to reduce our sepsis rates just by creating an evidence-based and experience and expertise-based educational intervention, which is open to all the Spanish units, which can, or even not only Spanish, but all units that can understand Spanish. And it's mainly composed of these chapters of these areas. Yes, our unit has some changes, has perceived some changes and benefits just from the surveillance, first of all, and the added intervention to reduce the detected high rates. Some of these changes belong to changing materials used. For instance, there are the anti-reflux valves, just prefix syringes instead of manipulating too much, just specific, very aseptic ways of creating the nutrition, the parenteral nutrition and administering them. Just building or putting a specific trays for all the material needed to insertion or maintenance of lines. And of course, surveillance provides us with information about rates themselves and with extra information about some procedures. This graph gives us information about how many of the insertions of peaks, in this case, are done using checklists and with all the things well done according to the checklist, or with some deviation from the checklist, the rule. Okay. All in all, these are a lot of changes. So we could see, going back again to the surveillance, that we had a sharp decline in our sepsis rates. So good news. This is the calendar in the unit, with number of days without any sepsis. So it looked like things went well, but we had some perception that there were some barriers still to get through. We perceived that we lack culture of self-criticism, positive self-criticism, of course, critical evaluation of procedures, in order to learn from what is not going well for improvement. Lack of tradition of teamwork, and I mean by teamwork, just multidisciplinary teams. This is a very important point regarding safety. And other problems, lack of recognition of the importance of time for quality improvement activities, a lot of changes in the unit in terms of personnel, which creates a lot of anxiety. You have to teach again the people, the newcomers. It's always a problem. Still, we don't have a routine assessment of hygiene compliance performed at our hospital, at our neonatal unit, I mean. So we could see that after the first boost down to decrease the rates, things are again going a little bit back to the beginning. So we see that we still need to improve things, but all this knowledge is provided by the surveillance system, which is a key point in all this story. So some reflections from our unit. We have seen that after information from the surveillance, warning information, and in some intervention, there was a sharp decline in the sepsis rates. There was a real change in a lot of things, but now, despite all this effort, we see that sepsis rates are increasing back again. So we can appreciate that there are still a lot of barriers and challenges behind us, in front of us. The compliance assessment, we think, is a very important point. We need to reinforce periodical, stable meetings, multidisciplinary, looking at how things are going, trying to improve. There is always something to improve on. We need, as Katerina said before, we need a lot of feedback. Everyone working at the unit, everyone visiting the unit as a consultant needs to know our data, needs to know how can they improve this data. So this is a keep on kind of activity. I just want to finish, I don't want to bother you too much, with a recent editorial published in the British Medical Journal, which shocked me. This is the statement by Martha's mother. Martha was a 13-year-old girl who died from a sepsis episode in a British hospital. She said, I think it's to The Guardian, the hospital where my daughter has died has confirmed me that her death has nothing to do with the insufficient resources of overstretched doctors and nurses, but it has to do with the way that hospitals work in silos and the predominant culture dominated by hierarchy, status quo, and overconfidence. So I think this is a common problem in high-income countries, at least. It's not only about technology, it's about people and how we can do to improve things. So every sepsis episode, especially in any war, is a catastrophe. Why don't we do what we can do just to make these episodes don't happen again? Thank you very much for your attention.
Wonderful. Thank you, José. Again, if you have any clarification questions, then please just raise them in the chat or raise your hand, but probably easiest to deposit them in the chat unless there's something super urgent, but everything seemed very clear to me. Thank you, José. And we'll come back to this and discuss everyone's experiences a little bit further down the line. So it gives me pleasure to introduce our next speaker, Dr. Christina Obiero. Again, Christina and myself have collaborated on several projects, and it is a great pleasure to be working with her and for her to be here with us to share her experience. Christina is a medical doctor with public health training from Johns Hopkins Bloomberg School of Public Health. She currently works as a clinical researcher at the Kenya Medical Research Institute, so KEMRI for many, which is the Wellcome Trust Research Program in Kilifi, Kenya. And she has led various research activities focusing also on neonatal sepsis and management thereof. She's recently completed her PhD at the University of Amsterdam. And she is now leading work within another project that we are working on together called SNP Africa, Severe Neonatal Infection Platform Africa, where we are also considering how to address this issue of surveillance. So Christina, the floor is yours. Thank you.
Well, thank you, Julia, for that kind introduction. So I hope you can all hear me. I'll give an overview of surveillance in LMICs. And I'm going to start off by just briefly mentioning the burden of infections among neonates in LMICs, and then talk of the role of surveillance in the settings. And then I'll mention about the platforms that are available in Kenya, particularly focusing on the Kenya Medical Research Institute Wellcome Trust Research Program, where I work. And then I'll talk briefly about the work that we are currently planning, which is the SNP Africa project. So serious bacterial infections are among the leading causes of neonatal deaths, and these are associated with long-term neurodevelopmental impairment, as shown here, if they are not adequately treated. And LMICs carry the highest burden of neonatal morbidity and mortality, as shown, and concerted efforts are urgently needed to end preventable deaths and also improve survival of neonates who continue to face regional disparities when seeking healthcare in these settings. So when it comes to surveillance of healthcare-acquired infections, surveillance studies are useful in characterizing the burden of these infections and also characterizing antimicrobial use and resistance and colonization with resistant bacteria. Although surveillance studies are less resource intensive and compared to other studies, such as cohort studies or clinical trials, they're not as simple to implement in LMICs where validated and context-specific protocols for conducting surveillance are missing. So this slide shows a systematic review and meta-analysis that was recently published of point prevalence surveys that were done in Africa. And this study found a pooled prevalence of about 13% of healthcare-acquired infections in the African continent. And this is about 2 times that prevalence that's reported in some developed countries. And the other thing that was found on this study is that only 40% of the healthcare-associated acquired infections that were reported actually had a positive microbiological culture result, and gram-negative bacteria were the leading pathogens that are causing these infections. Few point prevalence surveys were reported to have been conducted in the Central African region compared to the rest of the continent, and this shows that the results may not be generalizable across other LMIC settings, particularly since the analysis found that there's a high degree of heterogeneity across the studies that were included in this analysis, heterogeneity in terms of the methods used in the surveys and also in reporting. So the study that's highlighted in yellow on this figure is the only neonatal study that was included in the meta-analysis. So there's a scarcity of studies, surveillance studies that are including this vulnerable age group. So when it comes to antibiotic use in the LMIC setting, a high prevalence of antimicrobial use has been reported in Africa, with up to 80% in Nigeria. And this is despite the low microbiological testing that's to be used to guide stewardship programs. And the global point prevalence survey that was conducted in Tanzania, Zambia, Uganda, and Ghana across 17 hospitals found that there was about 50% antimicrobial use in these hospitals, and they reported that none of them used the WHO reserve category of antibiotics, but in other studies, we've seen that these antibiotics are used in LMICs. And when it comes to the neonatal age group, only 11% of the studies, or rather the total number of patients included in this study, in this survey, only 11% were neonates. And in Tanzania, use of antimicrobials for risk factors for newborn associated conditions was the second leading indication for use of antimicrobials in this setting. Next, I'm going to look at surveillance platforms that are available in LMICs, particularly focusing on the ones that you have in Kenya, and essentially the ones in the KEMRI Wellcome Trust program where I work. So we have two main platforms. So over the year, the KEMRI Wellcome Trust program has established surveillance platforms supporting clinical care and research in Kenyan hospitals. So on the left side is a Kilifi surveillance platform, and this includes hospital-based surveillance for bacteremia at the Kilifi County Hospital, which is along the coast. I don't know if I have a pointer. Yes. So the Kilifi County Hospital is located somewhere here, and this is along the Indian Ocean is here. So it's along the Kenyan coast. And the surveillance, under this surveillance platform in Kilifi, admission clinical data, outcome data, and microbiological culture results are collected on an electronic database, and this has been done since 1998. So all admissions, including neonates, have a blood culture done at admission and following a clinical deterioration. And then in Nairobi, we have the Clinical Information Network. So this is still under the KEMRI Wellcome Trust program. And the network, through partnership with the Ministry of Health and the Kenya Pediatric Association, supports the hospitals in improved documentation of neonatal and pediatric data, and embeds research in routine clinical work. So an example of the research studies that are embedded within this network is the Clinical Information Network Antimicrobial Resistance Project, which is a prospective surveillance for bacteremia and AMR in 12 hospitals, which are linked to high-quality microbiology laboratories. So over the years, the network has been able to add neonatal units to the surveillance platform. When it comes to studies that we've conducted in our program, essentially here in Kilifi that have done surveys, one of them is a NeoIPC study. So the NeoIPC study was a large prospective cohort study of the causes, clinical signs, patterns of antibiotic use, and clinical outcomes of neonatal sepsis. 3,204 infants aged less than 60 days were enrolled in this study across 19 sites in 11 countries, which are predominantly LMICs. And enrollment was based on an eligibility criteria that comprised of a set of clinical and laboratory signs. So the main NeoIPC study results were published mid this year, and the key results included high antimicrobial resistance and also significant divergence of antibiotic use from the WHO recommendation across the sites. So during NeoIPC conducted a one-day point prevalence survey of infections, risk factors, and antibiotic use in the neonatal unit. We collected unit level data and also anonymized patient level data on 2 separate days using standard case report forms. And so some of the case report forms are shown here. on this slide. So the data analysis is ongoing, so I'm not able to share the results of this survey. However, I'll highlight some of the experiences we had while conducting the survey, and this may serve as learning points for us for future surveys. So the slide shows some of the case definitions that we used for infection syndromes during the point prevalence survey that we conducted. And some of the definitions differ from those used in other point prevalence surveys in other settings, making it challenging to compare results across different settings. And therefore, the use of consensus case definitions should go hand in hand with the use of standard, validated, and context-specific protocols for surveys. Other factors that may affect the estimation of the burden of infection include missed cultures for those results that are not available on the days that conducted the surveys. However, this is expected given that we were collecting data to get a snapshot of what was actually happening in the neonatal unit. And then we did not collect data on clinical signs or outcomes, and will therefore not be able to assess risk factors beyond the presence of indwelling or invasive devices or procedures. Then the point prevalence results are not ready. The NeoIPC study was conducted between 2018 and 2020. This means that by the time the results will be out, we will not be able to use them in a timely manner, if I may say, to inform infection prevention control strategies and antimicrobial stewardship practices, but they'll still be useful. So next, I'll talk about the SNP Africa project. SNP Africa is a recently EDTCP-funded project that aims to establish a clinical research network and architecture to implement adaptive platform trials in sub-Saharan Africa. So the project is responding to the urgent need for improved treatment of childhood infection in the era of increasing antimicrobial resistance, and comprises of partners from the global South and North, as shown in this figure. So the project aims to conduct an adaptive trial in the ESBL drug regimen domain and up to 2 pharmacokinetic studies in the dose domain. And we'll also conduct surveillance of neonatal sepsis epidemiology and management at participating hospitals. And in addition to this, training and capacity building and stakeholder engagement and integration components will be implemented alongside the research work packages. So when it comes to surveillance, we are planning to set up a surveillance platform for continuous collection of a minimal set of key clinical and microbiological culture results, so key clinical variables and also the key microbiological variables. And then we'll also have the data that's collected during the surveillance monitored real time on a dashboard. And while you're doing this, you're going to perform statistical modeling. And we hope that the modeling, or rather the analysis that you do, is going to help us to derive alert signals for outbreak prediction and inform actionable points such as implementation of infection prevention and control measures in case an outbreak is predicted in a timely and early manner. And then we'll also work with participating sites to streamline the processes in the microbiology labs. And this also includes training and capacity building components. And the other thing we're going to do under this surveillance is assess invasive and carriage bacterial isolates using molecular diagnostics. So the surveillance will be conducted at 7 neonatal units, and these are located in 5 sub-Saharan African countries, which are part of the platform of the network. And as shown on this table, the neonatal units have different levels of care, levels of resources. You only have 2 that are able to give intensive care. That's in Ghana and South Africa, Tegaba in South Africa. And they have different levels of capacity and clinical care practices. And the same applies to the microbiological lab processes. This vary across the sites. So you'll need to work out how to have the differences streamlined while conducting the surveillance in a manner that also doesn't bring a lot of burden to the site in terms of data collection. And in addition to continuous collection of clinical and microbiological data of about 3 years period, we will undertake quarterly point prevalence surveys, whereby we'll collect environmental and rectal swabs from the neonates who are admitted in the units on the day of the quarterly survey. Planning for this surveillance is currently underway. This is information that will be shared in a future meeting. And this brings me to my last slide. Thank you.
Thank you, Christina, for sharing your perspective and your great experience. I believe all the talks have given some idea or impression that this may not be easy to perform surveillance. However, the results will be most likely worth the effort. And thereby, I would like to give floor to our last speaker, Dr. Brar Piening, who will introduce the NeoIPC surveillance toolkit that will be available for all of you on the NeoIPC webpage. Brar is Senior Infection Prevention and Control Doctor at Charité Institute for Hygiene and Environmental Medicine in Berlin, which is also Germany's National Reference Center for Surveillance of Nosocomial Infections. And he has been working in infection prevention and control surveillance systems since his student years for over 20 years by now. He is also the scientific coordinator of the German surveillance system for high-risk neonates, and within the NeoIPC project, he carries the responsibility of developing the tools for effective surveillance and making them available for all of you. Please, Brar, the floor is yours.
Thank you, Tuli. I will share my screen. I hope you can see it right now. Okay, I start with my conflicts of interest, which I would say are, or I always tend to say are basically none, but there are one. I belong to a school of like epidemiologists and infection control doctors who believe in the fact that surveillance just works. And I've been working in this field for, I can now say I'm 48, almost half of my life. And yeah, so this is my major conflict of interest. If I'm biased that what I'm doing is makes sense and that surveillance overall makes sense. What am I talking about if I'm talking about surveillance in the neonatal intensive care unit? As we already heard, neonates are very special children. If you look at global health data, you typically have the category children less than 1 year old, as Katarina, for instance, showed in some slides. And I think all neonatologists and pediatricians will agree that this is a very broad category, that not all neonates, or that you cannot simply call neonates children with less than 1 year. This doesn't fit the population, and this is a problem because we are really lacking data worldwide on this. Where we are not lacking data is Germany. If you look at this, this is just one screenshot from our current reference data. Sorry, it's German, but I will translate the most important bits. So this is the category of infants with a birth weight of 500 to 1,000 grams. Basically, we have in Germany alone 206 participating departments who contributed in the 5 years of this reference data period, 15,000 patients in this category with around 700,000 patient days. The mean surveillance duration is 47 days in this population. We know the central line usage rate. We know the invasive and non-invasive ventilation rates, and we also know the antibiotic use, as well as the infections, pneumonia, sepsis, and necrotizing enterocolitis. And what we also know is the antibiotic use per 1,000 patient days. And if I run a NICU in German or in a country that is similar to Germany, I can go to the NeoIPC website and just look at these data and compare my surveillance data, which I'm currently collecting, to these data. I have to admit that one part of the success of the NeoIPC system, Katarina already mentioned that there's the voluntary and the mandatory surveillance. Germany is a country where surveillance in the NICU is mandatory. So we basically cover the whole German population in the surveillance system. But now, after just showing you what can be there in theory, but is not there worldwide, I want to move over to the NeoIPC surveillance toolkit, which is a set of... Sorry, somebody's unmuted, but maybe you can resolve this, which is a more or less a free set of tools to support surveillance in NICUs worldwide. This is what we aim at. And the big question is, why is it a surveillance, or why do we call it a surveillance toolkit and not a surveillance system or a surveillance network? The reason behind this is that I have no idea of the circumstances you are working in. I have loads of experience of surveillance in Germany, in a high-income country where there's little lack of resources, where we have a fixed nurse-to-patient ratio and the like. So there's a lot I can tell you about Germany regarding neonatal care, but there's very little I can tell you about your country. And when during the planning phase of NeoIPC, I first talked to Mike Charland, I basically found out that I know very little about neonatal care after 20 years of working in that field, because he showed me data of low and middle income countries that were so strange to me that I could rarely understand them. So this is why I don't think that I can solve all your problems and advise you on everything you may want to do. But what I can offer is a bit of experience in the field. I've been running a surveillance system for, as we said, a long period of time now. And you might know that the KISS system is, the German system is called KISS, which is an acronym for the German Krankenhaus Infektions Surveillance System, which might sound very German and strange to you, but it is also an acronym for Keep It Simple, Stupid, or the KISS principle, as you probably know, which actually is an absolute accident. This was not planned when the KISS system was funded, but it happens to be on spot, actually, because one of the major stories behind the success of the KISS system is that we always try to compromise on simplicity and try to keep it as simple as possible regarding methods, definitions, and the setup of the surveillance system. So the toolkit we will offer you a basic set of methods, of definitions. We will offer a standard format of reports. But it is also planned to fit in various settings. So you can start collecting data on paper with paper and pen and calculator. There is an electronic system, and it is also possible to semi-automate this, so to feed data into the system from another computer system. And what we also want it to be is to be reusable and extensible. So there's no licenses, or there is, if there are any licenses, we try to make them as simple and as liberal as possible, so that you can just grab the things from our website and start your local or regional deployment. do not have to reinvent wheels or just fight against some strange copyright issues or the like, but rather just take the things and try to work. And we also plan to adjust and amend them based on requests and feedback we get. What does it currently contain, the NeoIPC surveillance toolkit? We have a surveillance protocol for high-risk infants, which is on the website of the NeoIPC website in the surveillance section. We have printable data collection sheets, which you can take to pre-collect data that you later feed into the electronic platform, but also in theory just to collect data and manage your data without an electronic platform, which is maybe only a thing you can do in a small setting, but still it is possible. We also provide training material to better understand the definitions and the protocol. We've developed a web-based data collection platform where you can collect data and generate reports, which is based on the DHIS2 system. And we will provide basic implementation support. This is more or less limited by the resources we have, but still we will try to support you if you want to implement the system. So why do we or what are we doing when we talk about surveillance in high-risk infants? So the definition in the protocol we currently have is infants with a birth weight of less than 1,500 grams or a gestational age of less than 32 weeks. And why do we do this? I don't have to talk to you about the burden of infections. We've seen multiple slides already today that it causes that hospital-acquired infections and antibiotic-resistant cause relevant morbidity and mortality in this population. I just want to mention why we focus on the high-risk infants. The thing is, as we heard already, it's about labor, it's about workload that we need to try to reduce and make feasible to the staff and the resources we do have. And in general, if you focus on high-risk patients, you can gather a lot of quality indicator data, and later on, all of the patients will probably benefit from IPC improvements. So this is rather trying to reduce the workload without reducing the IPC improvement potential. What do we currently cover in the system? Outcomes, we currently focus on nosocomial, so on late onset infections. We do have a definition for clinical sepsis. So after Katarina's terms, this would be a syndromic surveillance, but we have also the bloodstream infection, which would be lab-conformed bloodstream infection. So we have a hybrid system in that sense. Surgical site infection, pneumonia, and necrotizing enterocolitis. And we also observe some risk factors, common ones or some more experimental or new ones. The central lines obviously are very common. Peripheral venous lines also bring some burden, as we know from the NeoIPC system. We look at ventilation, non-invasive ventilation, antibiotic use, but also kangaroo care as rather protective factors, or human milk or probiotics. So now, how can you, we have already found out that there's quite some interest in this topic. So how can you potentially participate or collaborate with us as NeoIPC team, or how can you make use of the toolkit? There are obviously multiple ways to do so. You can just, if you feel like it and don't have plans of a lot of networking, you can just start in theory tomorrow with your hospital. Within your hospital, just download the data collection sheets and start collecting data, put them together, calculate the rates by hand, depending on the number of infants you have to manage. This might be feasible, as we already seen from our presentations. There might be between 30 very low birth weights infants a year in a unit, and 80 admissions a day in some African units. probably not all of them very low birth weights, but there's a huge range. So I cannot foresee how the data management could look in your setting. And yeah, you can also found or find a regional national network and maybe work on existing or newly set up national regional DHIS2 deployments, which just integrate the NeoIPC surveillance toolkit. And you can, in theory, also participate in the NeoIPC surveillance that is currently managed by Charité. So we have a European Union-based DHIS2 deployment. Obviously, since we are based in the European Union and we have the general data protection rules in place in the European Union, we need a collaboration agreement for this, just to be compliant to the GDPR. And yeah, if you are interested in taking part of this is also possible, but it brings some administrative work with it. And the basic thing is, as long as you are using methods and definitions from the toolkit, you should be compatible with the published reference data, and you can compare your data with whatever we publish from the network and look at it. Yeah, just a brief mention of the DHIS2 platform for those who don't know it. I think many people from the low and middle income settings will already know it, but this is an open source web-based platform. It is most commonly used as health management information system, and it is deployed in more than 100 countries. And it is the software development is in general global. I think it's from there are developers from 17 countries, but it's centrally managed at the University of Oslo. So it is quite a successful platform, and it's free and open source, and it has a rich set of features. That's why after initial evaluation, we decided to build on this platform with the initial data collection for electronic data collection for the NeoIPC. So what is planned? For sure, we will publish reference data the moment we have a minimum set of data in the database. We are currently working on advancing our reports. This is my project, I would say, for the month of December, improve the infrastructure to support translation and publication of tools, because we found out that language still is a barrier for many of us. And while between scientists, English typically works, the moment you get closer to the actual work on the units, there will be language barriers, and we don't want to leave anybody behind who can contribute to the project just because of language issues. So I will try to provide a minimum set of translations and maybe also crowdsource some further. We plan to have a metadata package for DHIS2, which would help you to integrate it in an existing system. Capture support, we only currently support tracker capture. Capture is the new capture thing in DHIS2, which currently is not supported because it was new when we developed the system and is not yet feature complete. We also think about supporting mobile devices, which is in the high-income countries not the highest priority, but I've learned that in low and middle-income countries it is a high priority. And we also have the plan to add early onset reporting, early onset sepsis reporting. Maybe we will. We had discussions about other forms of surveillance, like including the whole unit. Maybe with a more limited approach of surveillance because there's more patients than in there, or a point prevalence surveys where you cannot do incident surveillance, ongoing incident surveillance. Also advanced IT infrastructure, data transfer protocols, FHIR interfaces. This is probably rather something that helps you if you have a patient data management system in place, maybe in high income countries, but maybe also in some low and middle income countries. We will see. This is definitely a future thing. And yeah, obviously more training material, more stakeholder involvement, parents, policymakers. So there's a lot of things we can do, and it depends on your interests and your collaboration, what will find which priority in our future work. Yeah, and then in the end, I have a small poll. If you just type into a mobile phone or a browser, slido.com, and enter the hashtag NeoIPC, or just scan the barcode on the left side, we can probably find out what your plans regarding hospital-acquired infections are. I give you maybe 5 minutes, 2 to 5 minutes, and then I think we will move ahead. Yeah, that's the first people joining.
We can perhaps leave that up there for a second, Brar, and
yes, that's a good idea.
Direct one of our questions to you to make good use of the remaining time. So I'd actually like to address the question to both you and Christina, if I may, but maybe start with you, Brar. So Dr. Tunde Ayeye from Nigeria asks, what's the impact of basic cleaning and hygiene of facility and equipment on neonatal infections? Is there any data that speaks to such a basic but important issue, especially for those of us in low and middle income countries?
Yeah, I would say yes, it kind of depends. And I agree that this is probably a focus on that you need to have in low and middle income countries where, as you mentioned, there are few standards regarding cleaning protocols. Coming from a German perspective, where we have very strict cleaning protocols in place, and which are observed and also under some sort of surveillance, I would say in general this plays a lower role. But yeah, this is the basic infrastructure you need to have in place before you can neglect it. And I would say I typically tend to neglect it because yeah, this is more or less a solved problem. But yeah, it might occur that in outbreaks or due to cross-contamination, you have to put a focus on it. And we had outbreaks where we had very clear evidence of contamination of medical products or other devices. So even in high-income countries, you sometimes have to put a focus on it. But in the day-to-day basis, I would say I consider this as a solved problem, but only if it is solved in your setting. That would be my comment to this.
Perfect. Christina, do you want to share some of your observations from working with newborns, acutely sick newborns in a resource constrained setting around sort of environmental cleaning and basic standard measures?
Yeah, thanks, Julia. So in terms of cleaning, environmental cleaning, that's been, I mean, we practice that in LMICs in the setting I work at and also in other similar settings. And there have been studies that have looked at the role of that in prevention and control of infections. And I feel that it's now leaning more towards having IPC bundles where you have a combination of different interventions that can be implemented together to reduce or control infection spread within the neonatal unit. I'm happy to share papers that have been published in LMIC settings looking at the impact of using different IPC bundles in neonatal units to control the spread of infection. Over.
Thank you. Excellent. So we've had another question that was directed towards José and Begoña, and maybe Katerina has some thoughts on this also from a more policy perspective. Vicky, who's from Southampton, shared that they also implemented a targeted CLABSI bundle in the tertiary NICU and had an initial reduction in infections, but this wasn't sustained. And ethnographic research identified a lot of the barriers that you also talked about, José, and that you and Begonia were experiencing. And Vicky's interested to find out what your thoughts are on how to overcome social norms relating to IPC behavior, and in particular what all of us, or all of you, I should say, so the panel believe to be effective feedback strategies that drive IPC behavior change. And she just adds to this that she felt that maybe sharing some of the surveillance data locally didn't always have meaning or wasn't always believed by everyone who was addressed by the data. And I assume, Vicky, that maybe to some degree you also mean people who are very involved with clinical care and maybe not necessarily so much focused in the IPC intervention specifically. So I don't know, José, whether from a sort of implementation perspective, or Begonia, whether you want to share some of the things that you've tried and found to work or not.
Begonia, do you want to go ahead?
As you want. If you want, you can start, and then I will go on.
Well, I think that that question raises a lot of important issues. I think that there are several experiences, not only in neonates, but also in adults, of success at the beginning, after some intervention, and then as we are going just starting to experience things getting worse back again. So probably the fact there are a lot of things involved into this U-shaped time trend. Probably you have a lot of enthusiasm at the beginning. You push a lot of effort. You do your best or more your best, and things get better. And at some point, you are very happy, and you turn your eye to another problem that you have in the unit. Units are full of problems, of course. And then you start to relax a little bit your discipline, let's say that, in order to implement all the components of the bundles, and things, of course, go worse. I think that's a common experience. We have shared with you some of our perceptions. I think I would say that, first of all, it's very important for me that the whole unit knows from the very beginning that there is a campaign against infection, okay? There's a fight, there's a war against infection. And we should be talking about this war, and you are a soldier in this war. Sorry for the military jargon. I think it can be maybe useful for just in terms of thinking about it. And everybody, of course, needs to know what can she do, because I think all the people, we all bring germs to the unit, and we can do something to prevent germs entering the unit or moving across the patient, etc. So first of all, a lot of information and a general sense of there is a general campaign in this unit against hospital-acquired infections. First of all, then we in our Spanish project we have a forum of people. We started, of course, talking about very specific aspects of line injection, etc. But then people move into surrounding topics like parental nutrition and other things, and they were sharing with us some of their ideas. There are Spanish units, at least as far as we know, that are using WhatsApp in order to get all the people informed. There are some units which have created some local web pages where they put material, information about meetings, tools. So I think that there are a lot of things that you can do in order to keep people a bit stretched in the sense of having to think about infection prevention is infection. Of course, not training is very important. So feedback, surveillance is key. Surveillance plus feedback, training, education. I think this is all you can do. But, infection is one big problem, but there are also other problems. High turnover of people, sometimes lack of infrastructure, or breaks, a lot of things. It's all I can say. What do you think, Begoña?
Yeah, it's more or less the same. Well, now we are in a course related with catheter, ultrasound catheter, and it's the first time they have asked for us to explain our project and to explain the surveillance system. So it's a good thing that the people is worried about the infection and as José Ignacio said, it's really important for the unit to receive the feedback, because you must know the numbers and you must think about them as a tragedy. It's like that, because as you can see, in a very low birth weight infant without sepsis or without infection problem is a very good way, and know with sepsis on your way, on your path. And another thing we have found as a problem is the not only the people at the unit, the nurse, the auxiliary nurse, and it's all the people around the baby, the cardiologist, the radiology, that they must know that we are really worried about the infection, because sometimes it's really difficult, for example, to ask somebody to clean their hands. And it's really stressful. Can you wash your hands? If you make like a position of the unit that we are really worried about the infection, probably the things will go better, I think. But yeah, thanks.
Just, I only want to add one small aspect. That is that I think it's a general trend or general feature that in every hospital, almost in the hospitals, most of hospitals I know, the neonatal staff are very well known for being much worried about hospital-acquired infections than other professionals. They care more for washing hands. We have been told that in several places, Begoña. So,
well, our IPC person related with the unit is connected as well. And I was astonished because in one of the meetings, they told us about the gold standard of hand hygiene used to be an old nurse, an old neonatal nurse, because they are really used to wash hands and to have everything prepared to be in charge of the baby. So I think we must be proud of our work, but we can't stop now, because every sepsis we can avoid is a success.
José and Begoña for these comments. And as we are running short of time, we'll probably take the last question for all the panelists, which is, I think, bringing to the one core intervention. If that would be, the question would be from Dr. John or the MLM, if to mention one improvement in current cleaning protocols that can positively influence neonatal care and infection control, what would it be? And I would be happy to have all the panelists to take a position here, although we have already opinions available in the chat. Please, Aikaterini, will you start?
Well, if I have the chance to answer to the previous question and to this one together. So I think that how we can change the behavior is the $1 million question, because it's not easy, it takes time. It's not only one or few reasons behind the specific behavior. And most importantly, the behavior is not the same everywhere. It differs. Countries, hospitals, professions, doctors have different behavior than nurses, but both have an impact on IPC. But we know that even if we implement the best interventions, they exist, the moment you leave the unit, almost similar infection rates will come back as before the interventions. So one important factor, and if you ask what is the single one thing that we can do, is sustainability of interventions. So, and I agree with Christina, it's not only one intervention, it's a bundle of interventions. We know that the impact is, that the best impact is when you implement the bundle of interventions, many interventions same time. And find the champion inside every unit. Make people, the staff, care about IPC, motivate them, engage them in a team working, so that they can all be involved in some type of intervention. So there's not only one intervention that makes the difference, is all the interventions together. And it's very important, the sustainability.
Christina, what would be your suggestion for the magic bullet? Although I know, or we all know, that there is no such thing, but the one and most important one.
Okay, I agree that behavior is very important. So behavior change is very crucial when it comes to infection prevention and control. But for me, coming from a low and middle income country setting, the most important thing at the top of my head right now is to have resources to be able to actually implement the infection prevention and control strategies or interventions. For example, most of the healthcare facilities in my setting do not have running water. At the tap. And when you're talking to a nurse in the rural community and telling her that she needs to go and, she needs to wash her hands before and after performing any procedure or handling the baby and other things within the unit to prevent infection from spreading from one point to another, and then there's no running water in the tap, and they have to go and wash their hands outside the building and the with water that's coming from a bucket, so a makeshift water dispenser. I think those are some of the things which are actually making it hard for some of the interventions to be implemented in my setting. And so we know that in order to prevent infections, we have to do this and that. But if we can have systems in place to facilitate healthcare workers to actually do what they need to do, then that would make life easier for most people in my setting. Over.
Thank you for raising this perspective. José, would you like to comment on this? One last.
What the specific question, because there has been a lot of things all around. Julie.
What would it be if you had to choose just one most important intervention? What would that be?
There's not 1 million, it's $3 million question. Well, it seems to me, I'm not a dermatologist, of course, it seems to me that that having a good education in hand washing is key, because these people, these infection prevention and control staff go to you, they teach you how to properly wash your hands. They show what happens when your hand is not clean, and you can just get very quickly into the problem of infection, or how can you be a vector of infection? And then I think that when you are just within this atmosphere of what you do is very important for prevention of infection, all the other things can be a little bit easier. It seems to me that hand washing and all the strategies, education stuff involving properly hand washing and just surveillance of hand washing and reporting people what they are doing wrong and that what they are doing well. It seems to me the key point.
Thank you. And Brar, would you take the final word before Julia will wrap up our meeting as we are running out of time?
The question was the one improvement in cleaning protocols, which, as I said, in my setting have very low priority in general. So I would rather stretch and say, yeah, the cleaning protocol, my cleaning protocol would be the WHO model for hand hygiene, like cleaning your hands. And it might be an interesting fact for some of you. Christina was just referring to adding running water to units, and we are in Germany discussing removing running water from units and rather propagating waterless care. So we clean patients with like towels and tools that are pre-configured and don't use running waters. This is a discussion we are having at the moment. So it might be interesting for some of you. So it is not a conundrum, the running water on the ward. As long as you have alcoholic hand rub, you can probably safely manage most of your situations. So I would say the WHO hand hygiene model would be my favorite cleaning protocol. And if you force me to environmental cleaning, it would probably be the incubators, just because they are closest to the patients, you know, and yeah, that's it.
Excellent. So I think we've had time at the end to reflect a little bit on some of the perspectives that were also mentioned during the individual talks. I would also say that maybe some baby-focused interventions would be really good, because this is such a particular group that has such particular risk factors. So I appreciate that Brar mentioned incubators, for example, but obviously there's all sorts of devices and exposures that are really very unique to the neonatal care setting. And so, you know, these are all opportunities that we could be using to think of them as IPC opportunities, and whether they can be harnessed or leveraged in some way to reduce infections affecting our very vulnerable and youngest patients. So with this, it's my role to close here and to thank you all for joining. Please do reach out to us. You can reach out obviously to Brar and anyone who's been talking here individually, but feel free to reach out to us as a group through our website, and we will make sure that we point you in the right direction. Do sign up to this to the CPN to receive some information about upcoming activities, and we hope to see you all very soon, and then maybe to hear from some of your experiences in using our toolkit, so that we can also continue to improve that. So thank you very much. Have a lovely evening or late afternoon or morning, depending on where you are in the world, and take care. Bye-bye.
Bye.
Thank you.
Bye. Bye.